You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Kathleen Calzone, Research Geneticist at the National Cancer Institute's Center for Cancer Research and member of the National Capital Area ONS chapter, to discuss the history of genomics in cancer care and how we arrived in the precision oncology era. Kathy was on the team that discovered the connection of the alteration in the BRCA1 gene with hereditary cancer susceptibility. AstraZeneca sponsored this podcast episode, which is brought to you by ONS. Thanks for joining me today, Kathy.
Thank you for having me.
Can you start us off today by telling me how you got started in cancer genetics?
So I like to think of myself as somebody who mutated, and that's a term we don't use as much anymore, but mutated into cancer genetics. I have always been, since I was originally licensed, an oncology nurse, and I was working at the University of Michigan in the breast oncology program as a research oncology nurse. So the program that I worked with was with breast oncology. And at the time of the discovery of the region on chromosome 17 that was found to be the gene BRCA1, the first breast cancer susceptibility gene, we had the region of that gene, but the need to begin to search for it. So that discovery, which was by Mary Claire King, was monumental because it pointed to a particular location on a chromosome. And then really the hard work began associated with trying to identify families in which we could do linkage analysis. The person who knew all of the breast cancer patients and their families was me as the research nurse. And at the time, I just thought of this as one more research study, and I needed a little bit of remedial training. But it was very clear to me as I quickly got into this that some of the core concepts associated with genetics, understanding concepts of linkage analysis, where you're looking at markers that point to different areas on a chromosome, the ability to both collect and analyze a family history in the form of a pedigree, the ability to understand some of the things that actually pushed us very quickly forward in regards to the narrowing of the region on the chromosome, all pointed to me just how important it was for me to become more educated in genetics. And it's not that I wasn't surrounded by remarkable people who knew the most about genetics and cancer genetics at the time, but I really needed to start with some of the basics, and ultimately pursued my master's in cancer genetics and then pursued my PhD. And so that's kind of how I got there. It really was something that I didn't envision when I got started.
That's really great. I think that that's one of the most amazing parts about oncology nursing, or nursing in general, is that, you know, we start in an area that we think, sure, I'll work in this department, or I'll work in this research group, and, you know, start doing clinical trials or something like that. And just the opportunities that open up to us to really want to do a little bit more of focus of a specialty area. And I think it's just, and there's so many different opportunities.
It's really endless right now. It's a wonderful opportunity to be an oncology nurse.
I can't agree with you more. Now that you've told us your history, Can you walk us through the history of genomics and cancer care?
Sure. I think the first thing is to correct any misconception. Genomics and cancer care actually really isn't new. A lot of us think of it as new because we're seeing so much of it in our day-to-day practice and its application to our patients, but it really isn't new. If we think about genetics, genetics can be the sophisticated sequencing that we do now, but it also can be looking at structural changes within our genome that impact how our cells grow and divide and do their job. And one of the first was way back in the 1960s associated with the Philadelphia chromosome, which was named the Philadelphia chromosome because it was discovered in Philadelphia. But this was a change that is called a translocation, where a piece of a chromosome is broken off and attached someplace else in people who have chronic myelogenous leukemia, or CML. And that discovery was very important because what they found is that when that translocation occurs, there's a change that results in a brand new protein and brand new fusion gene called BCR-ABL. And when I was first, and this is dating myself, right? When I was first as an oncology nurse on the inpatient unit taking care of patients, we used to take care of patients, and I did, that had CML, end-stage disease, and there were really very limited treatment options. It was really just very discouraging. And yet, by having this fusion gene, they were able to develop therapies that targeted that, Gleevec. And Gleevec, as you know, was approved back 20 years ago now, and is a standard therapy, not just for CML, but for other diseases. And it changed the whole course of how we treat that disease. But that framework of understanding the genetic underpinning of cancer really isn't new. It's just as the technology and our science advanced, our ability to discern the genetic changes associated with cancer became greater. And that led to the ability to develop these kinds of treatments. But, this isn't really new. It's been around for a very long time. It's just moving at a much more rapid pace than it ever has before, which is good because it helps our patients.
That's a really good way to explain it. I think that sometimes the way they change, even just the terminology. So going from genomics to now we're talking, a lot of times the use of precision oncology. And so, changing the words makes it seem like it's something new that is, on the horizon, or something, new that's happening. But like you said, the reality of it is it has been around. It's all due now a lot to just the speed at which things are being discovered and realized and used in treatment, I think.
Yeah, I agree with you. I also think that there's a lot of this that nurses understand, but they don't think of it as genetic. And that's just understanding a little bit more of the science, not becoming a genetic scientist, but to appreciate that you actually do know a lot of this. You just don't call it genetics.
Yeah, I think you're right too. I agree with that. So as I was just mentioning about precision oncology, there's a lot of people who have said that we have entered into the era of precision oncology. So can you explain what that might mean for oncology nurses, or how is there a difference in, like we were just saying?
Again, I do think that the concept of precision oncology is just terminology. It's just a way of describing something that's been there before. It's the ability to begin to look at the molecular features of somebody's cancer and make targeted treatment decisions. And those targeted treatment decisions could have been around for a very long time. So let's take an example of breast cancer, right? So many of us have always encountered people with breast cancer, and taking care of patients who have an estrogen receptor positive and progesterone receptor positive breast cancer. And one of the hallmark therapies used in that circumstance is tamoxifen, which was discovered back in the 1960s. So again, something that's been around for a very long time and was approved many, many, many years ago. And I think got its first FDA approval in 1977. And so it's a targeted therapy. It's targeting specifically those kinds of patients that have a particular kind of feature. This, again, is something that is just developing because of the advances in technology. And it's not just the advances in technology, it's that we can use these technologies at very low cost. So it makes it feasible, and our knowledge base continues to evolve. The thing that kind of bugs me about thinking about precision oncology as being new is that as nurses, we are all about taking care of that individual and that individual's family, and less about, it's everybody on the unit or everybody who's in the clinic. We are inherently thinking about the individual and what's best for them and how to manage their symptoms and how to educate them. So I think oncology nurses in particular, we've always been about precision oncology. The therapy is continuing to expand in terms of what's available and the sophistication in which we do the evaluation of tumors. But we've always been there. And in nursing, I think we are the essence of what represents precision oncology.
I absolutely love that example. I mean, just like what you said about, we know more about this kind of thing than we think about. And that is a great way to look at it, that, we have done primary care nursing or different things like that, and how we do get to know our patients, and we know the kinds of things that bother them, and work with them so diligently to try and help manage their side effects just their whole journey with their cancer diagnosis. I love that example, that oncology nurses really are the essence of precision oncology. Thank you for explaining it that way. I think that's going to be a huge aha moment for a lot of people. So in talking about the role of the oncology nurse, how is the role of the oncology nurse in genomics changing and expanding?
I think that the role of the oncology nurses spans the entire healthcare continuum. And I'm talking about from before birth to after death. And that's because of the expansion in technology and what we understand about genomics. So how in the world are we taking care of people before they're even born? So let me put some framework to this. If you think about people who have an inherited predisposition because they've inherited a copy of a gene that has a variant that's affecting its function, and they are someone who is thinking about having a child, that they're young and thinking about having a child, and they do not want to pass that on to any child that they may have, they may want to meet with someone in genetics and meet with other health professionals to understand whether or not they could use technology, which is available, so that they could be selecting an egg or a sperm that doesn't have that particular genetic change. We know that even in the context of recessive conditions, meaning that somebody needs to have a copy in themselves, but also another copy in their partner for that to pass on to their children, that couples will also choose to have the partner that hasn't been tested. Our role as an oncology nurse is, we're not getting into the weeds of that kind of stuff, but we do need to know that that is available, that people may be interested, that those questions may come up in individuals who are in a program where they're being seen because they're at increased risk, or they're a child of one of our patients and they're asking this question. You need to know that these options exist and how to refer them to people or point them to resources where they could get more information. So that's the very beginning of sort of thinking about this kind of thing. when we go on with the healthcare continuum, then you have the newborn. And newborn screening, which is that blood spot done with a heel prick on a newborn, most of that is not a genetic test. And most of that is being done for the purposes of identifying other kinds of genetic conditions or indications that there could be a genetic condition where very early intervention could make huge differences in the outcome of that child. But what's being studied now and over the last several years is whether or not we could do whole genome sequencing on the baby as part of newborn screening. And how would we handle that information? What are the ethical and legal and social issues of identifying things as a newborn? If it's an adult onset condition associated with a cancer susceptibility and something that wouldn't occur for 20 years in an infant or the baby, the newborn, do the parents need to know that? Would the parents raise a child differently based on that? And how do you manage the records over time? These are important research questions, but the capacity to do that technically is there. Whether we should do it, I don't think we know the answer to that, and how we handle that as individuals move through different healthcare systems over the course of their life. But this kind of thing is an interesting approach to trying to control and improve health outcomes in individuals. And as nurses, we need to appreciate that those kinds of things may be going on. We may encounter someone who has had this done or has had a baby who had this done, and they're asking questions about it. And the key thing is to know when you don't know and who is your resource to be able to refer them to answer those questions. But it is possible that we could be in a circumstance over time where we see a baby who may have a risk for an adult cancer identified using these kinds of technologies. Obviously, risk assessment, there's a whole host of different things that we do in terms of testing in people who have evidence that there could be an inherited predisposition to cancer. And in that setting, what's fundamental to the role of the oncology nurse is making sure that you're able to take a family history and being able to interpret it and to know how to refer in circumstances or talk with the healthcare provider if you can't refer within your own setting about the indications, and keeping current on that because it is a changing landscape. And we encounter a lot of those patients over time as they pursue screening if they have been found to have a pathogenic variant in a gene that increases their risk for cancer. As we move through and somebody who's diagnosed with cancer, we're already using genomics to predict prognosis in much more sophisticated ways than we did, several years ago. Breast cancer was one of the hallmarks of being able to integrate that to identify who really at the molecular level requires adjuvant chemotherapy and who may not, based on the level of risk, and being able to look at the gene expression in somebody's tumor. And even just knowing all of this information, both the gene expression and what if somebody did have an inherited susceptibility, the ability to develop therapies, like in the context of breast cancer, we'll keep that theme kind of as we go, where you've identified somebody who, say, has a BRCA1 pathogenic variant, develops cancer, receives treatment, but then needs to go on because they've progressed onto different treatments. They've developed therapies specifically associated with those kinds of genes, like the PARP inhibitors, just one of a plethora of different targeted therapies that are sort of changing the landscape of how we treat people with these kinds of things, and makes it even more important that we find these individuals and get them tested. As we go through the trajectory, obviously there's a host of different kinds of applications in the treatment of different kinds of cancer. And we do a lot now of both somatic testing, which is testing of the tumor, in addition to the classic testing that we think about of germline testing, which is testing, someone for inherited genetic changes. And the somatic testing can be done in a paired way and can be very informative in that circumstance where they use what's run on the germline to subtract from the tumor to actually see what's really tumor specific and have a much more specific kind of tumor outcome. But when you do that, if it's somebody who's never had a germline test, the patient needs to know, well, are there possibilities that you could find something in the germline? And of course, the answer to that is yes. And also that if they had a prior genetic test and had a variant identified, the kind of germline testing done in paired tumor testing and normal testing or somatic and germline testing is not the same as a test that's been optimized for germline analysis. And so what that means is that it will miss some kinds of variants, specific kinds of variants in the promoter region of the gene, which is the hurry up, get up and go kind of part of the gene, or in very large genomic rearrangements. Those kinds of things will be missed. And so it's possible that they could get a result that comes back on that test and they didn't find a variant that they know they already have. And so then the confusion of, does that mean that my other test was wrong, or is this test wrong? It's not that any test is wrong, but the person who's getting those questions and needs to understand some of that to answer those questions. And the person who is consenting people to those tests is often the oncology nurse. And then the other piece of the health continuum I think that's important is to think about symptoms. Oncology nurses are sort of the gold standard of symptom management in the team. And in many circumstances, they are the person that's the point person for how to deal with these kinds of things. And what we understand, all of us understand that, is that there's a lot of variation. Well, with this treatment, these people should have this, but then there's always these other people that where, some kind of toxicity that was unanticipated or that's very rare occurs. And much of that has a genetic underpinning. And the National Institute of Nursing Research has spent the last many years training nursing scientists in that area to really be the evidence generator for symptom science. And if you pay attention to some of what's coming out, well-respected oncology nursing symptom scientists like, Christine Mizakowski, who's out in California, what you'll discover is lots of different kinds of ways that she's studying this to help us understand, are we going to be able to utilize that as a way to preemptively identify people who would respond differently to different kinds of interventions or to different kinds of medications and be able to ameliorate some of those symptoms based on that information. And then lastly, anybody who works in clinical trials knows that a big piece of clinical trials is the collection of biospecimens for future use. And oncology nurses are involved in consenting and the collection of the umpteen bazillion biospecimens of all different kinds and what they may be used for. We have to appreciate that genomics and genes and genetic material is exceptionally stable. So let me put it into perspective. How stable is stable, right? Can it sit on the counter for like a week and still be good? Well, they sequenced the Neanderthal, right? So it's stable for thousands and thousands and thousands of years. And that means that these biorepositories and these different kinds of studies where we collect biospecimens, that there could be information that can be discovered that has implications that even could be something that comes to light after the patient has died. And we need to be thinking about making sure that we understand people's wishes, because who gets that information? If they're, when you're working with a physician and they find something that they have discovered that has implications for other people in the family, I have never seen somebody who couldn't help themselves. They have to get that information out, and they want to get that information out. And we should try to make every effort to get that information out because it can make a difference in terms of the health outcomes. It's not a genetic emergency like most of them will think it's a genetic emergency. But what's important to understand is, how do we do that? What are the ethical ramifications? What if the person who's the next of kin is the spouse, but it's a second spouse who never really had a relationship with the children where this makes a big difference? These are ethical issues that we as oncology nurses need to understand more about and how best to approach this, because it's challenging and it's only going to increase. Nobody's going to throw away biospecimens sitting in a repository. That's never going to happen. And so this can happen at any time and is something to think about. So in summary, I think that the implications for oncology nursing, it's not just about, well, I'm giving a targeted therapy and what are the toxicities I need to be looking for and how do I administer it? It's much broader than that, and it spans the entire lifespan.
Wow. That was a great way to look at, like you just said, the entire lifespan of patients that we encounter and families that we encounter. And you've really talked about how the science and technology has definitely evolved over years and how we as nurses are being brought into incorporating that genomics kind of information or understanding it into our care with our patients and families, all along the continuum. And so there is a lot for us to think about. And you brought up a couple really good points. There's a lot of ethical issues in all of this, and it's going to just expand as we are learning more and more about genetics and genomics and how that works and how the implications, for patients and their family members. So another thing that you talked about was the work that the nurse scientists are doing, with symptom management and things like that. So can you talk a little bit about how, the science of genomics, when we're looking at that, almost what I would call bench science, and then how we translate that into clinical practice? You've given a couple of examples in your last response, but can you maybe give us a little bit more information about the translation from that bench to clinical practice?
So I think the biggest example that I can give is one that is part of our domain in terms of symptoms, which is pain control, right? We are big in the pain control, working with pharmacy and the oncologist to, try to optimize that, working with palliative care. But what's important and what has been discovered, and not all of that has been done by nursing, is that the way we metabolize medications is based on genetics, right? That's how we metabolize many medications. And so let me give you an example. My father had to have several surgeries, of which one included one for colon cancer. And with his very first surgery, you always know something's wrong when he's the first case and there you are in the waiting room and they give you the phone at the end of the day because everyone is gone and they're leaving. So there's something really wrong, but no one has been in touch with you. And what happened was basically he had excruciating postoperative pain in, the recovery room, and they gave him morphine and nothing happened. So they gave him some more, right? That's sort of the standard approach. So much so that, he stopped breathing. So that's not good. And he ended up in the ICU. And to me, putting on the genetic lens, looking at what could have caused that, it was clear to me, and we didn't have to do a genetic test or collect a sample or figure anything out, but just to appreciate that this person wasn't responding at all to the medication that they gave him is that he had a variation in a gene that was preventing the right kind of metabolism and utilization of that medication. The thing that was so startling to me was that, I'm not a shrinking violet. And with my father, he ended up having over the course of his life 15 surgeries in total, the first one being the one I just described. Everyone, I'm not a shrinking violet, made it clear that this had happened before. 15 times, went into the recovery room, had intractable pain, continued to get morphine, which was not working, and ended up in the ICU 15 times. So think about the safety, the quality, and the cost. Since I was in charge of his bills, the cost, exponential. Those kinds of things are already there at our disposal. And we need to think about even our assessments, that understanding how genetics is playing a role in things like pain control, but also nausea and vomiting and peripheral neuropathy and, all of the toxicities that we see associated with medications. We need to be thinking about also another piece of it, which is the genetic underpinning and how that can inform some of the management. And to appreciate, we are not alone in terms of the health profession that needs to upskill in genetics. Many of the people on the healthcare team need to do the same. The key thing is knowing who to ask, find your resource, and know who to go to help you with that. Because it's just about taking an assessment and thinking about what happened and not just continuing to do the same thing because that's what we do here. It's, again, precision oncology, but in this case, it's precision symptom management. And I think the work going on in symptom management is going to continue to expand into these other areas over time as more and more discoveries are made about things that have real clinical relevance to our practice.
What a good example. That kind of makes me think about, with all of these discovery changes that are happening and things like that, what is our approach to risk or screening and treatment? Because, like you said, 15 times, so clearly, some screening may have needed to be done different or in a different way. So, yeah, that's very interesting how and that's a good way to talk about, what the symptom management pieces are and how that is also being impacted by, these changes as well. So now I want to hone in on your work. What was your role in the discovery of the BRCA1 alteration and hereditary cancer susceptibility?
So I was an oncology research nurse working with the breast program, like I had mentioned before. And so I was the person who knew all the women who were affected and some of the men. And I was involved in consenting people and recruiting people, taking the detailed family history. And then I worked, with the team to get trained on that and being able to evaluate families, families for these kinds of studies at the time, because we were doing linkage analysis. You're trying to link up different people in a family genetically and to look at patterns of these genetic markers across an entire family. And that's reasonably complex. So there was a team of people that looked at these family histories, and it's not that there weren't a wealth of people who wanted to participate, but very few families had enough individuals in the family that were full of individuals who were still living, where you could collect specimens from, and B, if they were still living, that everybody wanted to participate, because not everybody actually does want to participate in these kinds of studies, where you could reconstruct the family enough in the laboratory looking at the genetics so that you could identify where these markers were and whether you're narrowing down based on, their history that you think they have it, that you're narrowing down the region where that gene could be. We were very, very close at the time of being able to have a very, very narrow region. And we had never intended to give results based on these genetic markers. They research results. There was no reason to give them. And we intended to wait until we actually were able to have the gene in hand, and then you could test the gene and look for the specific variants in the gene that were affecting its function. But one day in the clinic, one of our very large families that we were taking care of, several members of that family came in for a follow-up visit, the person with cancer, and she came with her sister who had not developed cancer. Both were participants in the study. And when they saw the oncologist, Dr. Barbara Weber, they told her that the sister, who was unaffected and had seen people die in her family from this disease and all kinds of challenging sorts of things, have made the difficult decision to have prophylactic bilateral mastectomies because of the fact that she felt that she just couldn't live with this risk any longer. And she felt like she was a ticking time bomb. But what we knew based on the markers is that she didn't have it. We knew that in the laboratory. And so what occurred, and we actually published this, is we had several emergency meetings of great length to debate the ethics and the regulatory issues associated with disclosing genetic markers for someone before she actually had her surgery ready to go. She'd seen a consultant about it. She was ready to go and figure out, you couldn't in good conscience not tell her what evidence we had. But then if you tell her, you've got to tell everybody else. And if you tell everybody else in that family, what do you do with all the other families that we have? And what does that do with everybody else who's collaborating, in different centers around the world? Because this was an international effort to find these genes and to make these discoveries. So we were the first team to disclose a BRCA1 result in that setting. And we disclosed it to our families after we got a confirmatory sample, and we offered it to our other families as well. Once we went down that path, we were going down the path. And my role was the recruitment, the involvement, the collection of the families, the scheduling of all the visits, getting all the biospecimens for confirmation, being involved in giving results, being involved in all of the follow-up of all of these patients, all of it. And that really was the aha moment for me of needing absolutely to have, and I was working with extraordinary people. So to put extraordinary into perspective, our team, I worked with Barbara Weber, the oncologist, and the geneticist that we worked with was Francis Collins, who now runs the National Institutes of Health, one of the most renowned, geneticists in our country. So it was a real need for me to pursue more education in genomics.
Well, thank you. It must have been a very exciting time to be part of that team. So how did that discovery change the approach then to risk and screening and treatment for breast cancer patients?
The first thing that was very apparent in our very first family, we had someone who totally freaked out, hadn't had a mammogram, wanted a mammogram right away. And the first thing that was so apparent to me, so of course, we're oncology nurses, we're going to get it done. We got her a mammogram that day because it was all this logistics and the mammographer, working late and all of this. And we knew that she had, at that time, it was the markers. And the mammographer, the radiologist looking at the films, saw something and was going to, level it and for a short-term follow-up. But knowing, and she kept saying, so this person has it, knowing that this was an individual who had this genetic change, she made a different call. and decided to biopsy it, and it was cancer. And so, we were able to intervene at the earliest possible moment in a short-term follow-up, given the behavior of some of these kinds of cancers, which can be very aggressive in nature. It would have been something that could have potentially had a very different outcome. So it changes the level of suspicion. It changes the screening and when we do it. In certain circumstances, we're starting screening, much earlier than we would in the general population. We quickly discovered after the identification of the gene that there's more than just breast cancer associated with it. And that included ovarian cancer, but a plethora of other cancers. And as all of these cancer syndromes were discovered, we're finding the same thing. And so it changes the screening, what you think somebody's at risk for, what you would do, their management. Ultimately, it's led to changes in how we identify people, even for testing. And we're testing much broader populations of people than we were before. For example, just testing anybody with, early onset disease, or in breast cancer, triple negative breast cancer, ERPR, HER2 negative breast cancers. All men with prostate cancer of metastatic disease is an example. And so these kinds of changes have made a huge difference, in addition to the development of therapies that are targeted and different kinds of approaches to managing these patients, that when you encounter somebody at the time of diagnosis, would you want to test them before you make a therapeutic decision? And in many cases, we do that now, where we try to get the testing in before somebody would make a determination as to whether they would have a lumpectomy with radiation versus a mastectomy, because of the risk for cancer in the remaining breast tissue that's left behind, even with radiation. We know that that can still occur at a greater rate than what we see in women without these genetic variants. So it's changed the whole way we think about patients and how we treat them and what we do.
Yeah, thank you. That's really good way to look at probably how all of this is changing with genetics. Great examples. You've really given us so much information today, Kathy, and your expertise in this area is just amazing. I like to end our podcast with 3 rapid fire questions that I ask everybody. So I'm going to get ready for those real quick. First of all, and I think this is such an important piece, especially related to our topic today, what are some resources for oncology nurses wanting to learn more?
Well, ONS has done a really good job with this. They've set up a genomics and precision oncology learning library. It even includes a taxonomy to help you even understand, the genetic ease, the terminology, which is foundational to everything else. But there's all sorts of resources in there, including, glad you asked videos about common questions, different kind of programming, voice articles and forums. So there's lots of tools there. And I encourage you to go to the learning library. Cancer.gov, the NCI resource, has a host of different kinds of cancer genetic resources, including PDQ, which are evidence-based summaries that are updated monthly on common conditions like breast, prostate, colon, skin, etc. And the National Human Genome Research Institute, which is genome.gov, also has a huge host of resources, including learning resources through the Genetics and Genomics Competency Center for Education, or if you just Google G2C2, it'll pop up.
Thank you. Perfect. Next question. What is something about genomics in cancer care that's not often discussed, but you wish people knew more about?
The big thing is that people think they know who to go to ask, but when put on the spot, they actually don't know who to go ask when there's a genetic question. And we actually did a very large study in a magnet hospital that actually illustrated that point, that even the highest level people didn't know who to go to. I think that the big thing is just figure out who you go to when you don't know. And if you don't have somebody within your institution, like a genetic counselor, a geneticist, or someone who can help you, who has expertise in cancer genetics, then you need to utilize the networking through ONS to help you get connected, to find the go-to person. Best nurses I've ever worked with are the people who know when they don't know and know how to find somebody who can help them.
I agree with that. I think that's, such an important piece. And, as this is becoming more common, I think it's really important for nurses to know, because not only do they need to know, but they are going to have more patients that are asking these questions and asking, how do I get testing? Or, how do I know if my tumor has this certain alteration that people are hearing more and more about? So it is so important to know who to go to and where you can get that information. And then lastly, what are some misconceptions about genomics and cancer?
So a lot of people don't understand that at the level of the cell, all cancer is genetic, but it doesn't mean that all cancer is inherited, right? It just means that at the level of the cell, genetics is what's driving the growth of the cell. And we all know that, cancer is a disease of cells that aren't growing the way that they're supposed to. But, not all of the variants that are identified pathogenic. And what that means is that, you could have variants that are discovered that are completely benign. It's sort of like, think about cooking, right? All of us might make a chocolate cake. All of us might use a different recipe to do that. But at the end of the day, it's still a chocolate cake. And there's different ways to get there. And we need to understand the difference. And we need to understand when we don't have enough evidence to know the difference, like in the context of variants of uncertain significance. That's where mistakes are happening. And we need to be wary of that and to know when we don't know and find someone who can help you.
Kathy, I just want to thank you so much for joining me today and for your wealth of knowledge on this topic and your willingness to share with us. Do you have any final comments for us today?
Certainly always feel free to reach out to me. I think that it's good to network and to have somebody who can be a resource. And remember, genetics is not as hard as you think it is. And there's lots of resources to help you overcome that concern.
Well, thank you. And thanks for joining me. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.